Physiological and Psychological Changes in End of Life by Haley Ford, Olivia Molnar, Jamie Navarro, and Ariel Vicara. At the end of life, patients may undergo palliative care, which is specialized medical care for patients nearing the end of life. It doesn't cure their illnesses, but it can alleviate their symptoms. Patients can undergo change in consciousness, and consciousness is defined as the minimal neuronal mechanisms that are sufficient for any specific conscious experience or experience that one is aware of. So during the last stages of life, these neuronal mechanisms are altered in a way that can affect things like sleep, anxiety, fatigue, agitation, and delirium. Sleep is a complex function that is essential for our well-being, and it's managed by the circadian rhythm, which is also responsible for things like body temperature and hormone regulation. So a change in sleep pattern can occur at the end of life due to things like reduced activity during the day, medications, and uncontrolled pain. Sleep problems in terminal illnesses can include things like insomnia, disorders of the sleep-wake cycle, and excessive daytime sleepiness. And so to navigate these problems, patients in palliative care may do things like avoiding napping, being encouraged to have a regular sleep-wake in time, encourage physical activity, avoid caffeine in the evenings, practice relaxation techniques before bed, and consider therapy to talk about their worries that may be keeping them up. Anxiety may also be increased in end of life and is defined as the feeling of dread, fear, or overall uneasiness, and it can be caused by medications, cancer treatments, or poorly managed pain, or just the emotional response to dying. Some patients may even develop a panic disorder, and treatments will most commonly include procedures to combat the underlying cause. And in some cases, an SSRI medication can be administered, but it takes a while to kick in and can cause adverse side effects, so it's often not used. Fatigue is also increased in end of life, and it's one of the most common symptoms that patients will experience when they're undergoing palliative care. Fatigue is the feeling of being unusually tired or weak, and to assess the level of fatigue, they may go through something like the PQRST or ESAS pain assessment. And to treat it, the most effective treatment is just increasing aerobic activity. Agitation is defined as the anxious, restless, and unsettled behavior that patients may undergo, and it's caused by medications, their physical condition, or psychological factors. The best way to treat the increased agitation is to support the patient in whatever way they may need, whether it be emotional, physical, or spiritual. And in some cases, in the most extreme cases, sedation may be considered, but it does raise some ethical concerns. However, it does allow for a more peaceful death that has alleviated symptoms such as agitation. Delirium is generalized cerebral dysfunction, and there's 3 different types. Hypoactive is when the patient will experience lethargy, drowsiness, or diminished awareness of their surroundings. Hyperactive is restlessness, agitation, hallucinations, and delusions, and mixed is a combination of the both. To assess this, the patient will go through the Diagnostic and Statistical Manual of Mental Disorders, and to manage delirium, most commonly the patient will just receive support, and also to treat the illness that's causing the delirium. So on the photo to the left, there is a bunch of different types of illnesses that can cause this effect. Now we're going to look at digestive changes. So appetite loss, difficulty swallowing, and poor digestion. First, appetite loss. So a slowed metabolism, there's going to be lower calories and not much of an intake, so we're going to be trying to conserve some of that energy, so the metabolism is going to slow itself down. A loss in desire to eat, decreased need for energy, so because the patients are spending more time in bed than they were before, probably bed-bound, they're not going to be expending as much ATP, so they're not going to be ingesting as much food. And lastly, nausea, so that could be a product of anxiety psychologically, and that anxiety can induce the sympathetic nervous system, and that can cause nausea along with other digestive issues. And then also medication can cause nausea as well. So chemotherapy, if a patient is undergoing that, antibiotics can cause bacteria to die off in the gut, and also can irritate the stomach lining in general. Next, difficulty swallowing, also known as dysphagia. So 79% of patients who are undergoing palliative care actually experience some type of difficulty swallowing or dysphagia. A possibility of why this occurs is that they're not salivating from food, so a loss in appetite. The brain receptors might not be transmitting the neurotransmitters, and then the neurons won't be firing for the glands to produce the salivary enzymes, which those would help to break down the food. And then we can go into the 4 different phases of swallowing. So if you look at this picture on the slide, the oral phase can be broken into 2 separate parts. So first, the oral preparation, which also has to do with that saliva. It's going to combine with the food, and that will make a bolus. And if the patient is having issues with the salivation, then that's going to create a difficulty. But if the problem isn't there, it could also be in the oral propulsion. So if the tongue muscle isn't controlled or there's muscle dysfunction, that can create an issue with propelling the food down into the pharynx, which also leads into our next 2 phases, which would be the pharyngeal and esophageal. So those could also be muscular issues along with some type of disease in those areas, so that goes along with the weakened muscles. And then lastly, cognitive impairment. So the patient could have some type of dementia, if it's an elderly patient, or Alzheimer's, and it's possible they could put too much food in their mouth, and that would result in choking. Poor digestion can occur, so constipation is going to be the most common type because there's less water, less food. Also, pain medication can cause the stool to be bound. To compensate for constipation, there's often an overuse of laxatives, which can result in diarrhea. And then NSAIDs can also result in diarrhea as well because of irritation to the gastrointestinal lining. If diarrhea is occurring, then the patient can have trouble absorbing nutrients from their food like they should be, so they're resulting in malabsorption.
So with end of life, you're going to see respiratory changes, which is basically just irregular breathing patterns. There's going to be hyperventilation, apnea, and agonal breathing. Cheyne-Stokes disease is also going to occur, as well as increased mucus. The death rattle is just a bunch of loud noises that patients usually make towards the end of their life. It's when the patient is no longer able to swallow or cough. So you're going to have a buildup of mucus, which when the air crosses over the mucus, with this increased mucus, it's going to cause loud noises because the air is not going to have a big pathway to travel through. So the normal function of mucus, it basically just protects your respiratory tract. You're going to want some mucus in your airway. It's just when it gets built up that it becomes bad. But normally mucus will trap irritants in your airway, and you get rid of them either by swallowing the mucus or by coughing it up. Mucus also contains antibodies and enzymes used to kill bacteria in your airway. It also reduces fluid loss, especially around your organs. You want your organs to have some fluid to function. So mucus protects those organs from having any fluid loss. So with the buildup of mucus, that's when you're going to start to see problems. So as a patient is dying, you're obviously going to become weaker. There's going to be difficulty swallowing and coughing, like said before. The increased mucus is going to block those airways. This could eventually lead to collapsed air sacs and alveoli. Alveoli are responsible for gas exchanges between oxygen and carbon dioxide. So when those alveoli fail, that's going to lead to other health concerns. And then you're also going to get those loud breathing and loud noises as the air travels over the increased mucus. So the picture on the left of the picture, you have a normal bronchi. you can see how big the airway is. And there's still some mucus in there, but the airway overall is much bigger compared to on the right with the increased mucus, the very tight compacted airway. That's where your loud noises are going to come from, and your collapsed alveoli and all your other health concerns, especially near end of life. So compared to Cheyne-Stokes breathing, that's the irregular pattern of breathing. So on the right, you can see the picture of the normal breathing pattern is very constant. There's really no changes within the rate compared to Cheyne-Stokes, where you're going to have a period of rapid breathing followed by a period of no breathing, which is hyperventilation and then apnea. And this cycle basically repeats itself until you eventually die. There's really no way to stop it. So normal respiration involves a negative feedback loop, which is regulated by chemoreceptors, especially the peripheral and central receptors. Overall, they regulate your carbon dioxide levels. So for example, if you have increased carbon dioxide levels, your chemoreceptors, they're going to sense that, and they're going to stimulate and activate your breathing muscles to exhale and remove the carbon dioxide to bring it back to a balance. And then vice versa, if you have decreased carbon dioxide levels, those chemoreceptors are going to stimulate your breathing muscles to inhale to increase the carbon dioxide levels to bring it back to a balance. So overall, this negative feedback loop is functioning, and that's where you're going to get your normal respiration. With the Cheyne-Stokes respiration, you're going to have that negative feedback loop, but it's not functioning nearly as well, and you're not going to have that balance. There's going to be a lot more fluctuation in between your carbon dioxide levels. So let's say, for example, if you have hyperventilation, you're going to have that increased carbon dioxide levels. Your chemoreceptors, they're going to sense that. They're going to stimulate your muscles, and they're going to try to bring your carbon dioxide levels back down. But with the Cheyne-Stokes respiration, they're going to bring the levels down to an apnea threshold, which is going to cause no breathing, which is the apnea. And then your chemoreceptors are going to sense the lack of carbon dioxide, and they're going to stimulate your muscles to do the hyperventilation, and then you're going to get the increased carbon dioxide. So this cycle between hyperventilation and apnea, it just keeps going until eventually you die. This cycle also can cause cortical control to be damaged, which is your cerebral cortex, which is where all your voluntary motion comes from. So then your respiration goes into a metabolic control, which is involuntary. So without that voluntary control, you can't fix your breathing, so you just have to let it happen. So it's actually kind of sad. So finally, another symptom that you can see with respiratory changes are agonal breathing. You see this a lot in movies where somebody's dying and they have that dramatic last breath of air. That's basically what agonal breathing is. You have a lack of oxygen, so your natural reflex is to gasp for air. In movies, you see this as the last breath, but it can last up to a few hours of just constant gasping. So with decreased oxygen, you're going to get ischemia, which is decreased oxygen to your organs and decreased blood flow to your organs, and that eventually leads to death as well. So all of this is just a recurring cycle, and there's really no way to stop it with end of life.
Okay, so finally, I'm going to talk about family challenges that might occur when the loved one is in end-of-life care. For challenges in consciousness changes, sleep problems and fatigue can cause the patient to be too tired or not be able to wake up at all when their family visits. For delirium, agitation, and anxiety, confusion, restlessness, or dread or fear can also make it difficult for the patient to talk to their family and for their family to understand them. And due to this lack of understanding, it might take a mental toll on both the patient and the family, which might include depression. And due to these changes, the overall personality of the patient might change, and the family might not recognize the person sitting across from them, so that's a bit sad. And the family might also have to make decisions about the patient's care if the patient is not mentally capable of doing so due to all these changes. For challenges in digestion changes, the family will probably witness their loved one not be able to eat properly, so they might see their loved one
have weight loss and wither away a little bit due to appetite loss and poor digestion. And they might also see their loved one struggle to eat due to difficulty swallowing and the chance of choking. For challenges and respiration changes, the family will probably witness their loved one not be able to breathe properly, which can be really disheartening due to the inability to clear mucus and Cheyne-Stokes breathing, like it was mentioned previously. Some overall challenges for the family include feelings of anxiety, uncertainty, and feeling helplessness about their loved one's care because they're not around them much. And this is due to maybe unmet patient needs and wishes because the family might not know what's going on when they're not around. And then the monetary strain could also be a challenge due to ongoing care, which could also be followed with feelings of guilt for even worrying about money when their loved one is struggling. And one other challenge is coming to terms with death and loss, since this is care for the end of the life of one of their loved ones. So the family might experience grief. So overall, it will probably be difficult for a patient's family to witness their loved one in such a state. Here's our citations, and here's the rest of the citations. That's all.